Yet another panel of passionate speakers and excellent clinicians and researchers. And we have a topic that has been on our minds for a long time, but in recent times it has been given even more importance. Dr. Neeta, can you mute so that there is no echo? Right. So we have a very important topic that is very clinically very useful, and at an early stage, if we intervene at that point, we can really make a difference in patients with diabetes and obesity. And the topic is NAFLD and NASH, the importance, assessment, in whom, when, how, and what are the exact and precise action-based algorithms. We have Dr. Nitin Kapoor, who is a friend and a mentor for me, and who will be leading this masterclass along with the experts like Dr. Rucha Mehta, Dr. Altamash Sheikh, and Meenal Mohit. We have heard Dr. Nitin Kapoor in a couple of days yesterday, so we know him as a professor of endocrinology from CMC Vellore. And I would request you, Dr. Nitin, to take over, introduce the panel, and take up the topic.
Thank you so much, Dr. Anjali, and thank you, Dr. Neeta, again for inviting me for this particular masterclass, which is indeed a very important topic. And the moment I saw the name of our three experts who are going to lead us today to the discussion, I thought my job is fully done, because all of them are excellent orators and astute clinicians. So our first expert is Dr. Rucha Mehta. I think she needs no introduction to this August audience, from Ahmedabad, heading the cardiometabolic unit at Apollo Ahmedabad. And I think we've heard her every time on IDEC and so many other platforms. So we welcome Dr. Rucha. We also have with us Dr. Altamash Sheikh, good friend again. I've known Dr. Altamash for, I would say, 12 or 13 years now, and on so many platforms together. And welcome Dr. Altamash, leading endocrinologist from Mumbai. And we also have with us Dr. Meenal Mohit, who is another experienced endocrine physician from Jaipur in Rajasthan. Again, a very renowned physician. We all know her. Excellent career, as you can see, with so many medals across the span of education. So welcome, Dr. Meenal, as well. So over the next couple of minutes, and we really hope that we are going to stick to time, we are going to take you through this very important topic of NAFLD. And just to set the ball rolling, very briefly, I would tell as to why this is there today as a topic for the masterclass. So I think, what is NAFLD? I think we all are aware. NAFLD is, I would say, a spectrum of disease. It's a spectrum from just presence of fat in the liver, steatosis, to some inflammation, going on to fibrosis, cirrhosis, and at times even malignancy. But this entire spectrum of disease, with steatosis to cirrhosis, is essentially called NAFLD. By definition, we would say somebody has got NAFLD if they've got fat in the liver, that is hepatic steatosis, and by definition, at least 5% of the liver should be having fat, that is either by imaging or histology. And the other important factor that is really important to say is we should have ruled out common secondary causes of hepatic fat accumulation. So this is how we define hepatic steatosis. But why do we have this masterclass in one of the most prestigious conferences that we have annually in India, with the best experts that we have, the three best experts and orators that we have today? Why do we need to have a masterclass on NAFLD? And I think the reason is because it's not only a spectrum, the way I showed, from fatty liver to going on to cirrhosis, but it's also a spectrum of diseases that comes along with. And in clinical practice, when we see patients with NAFLD, I would say that we just need to take one step backwards outside the liver and see the bigger picture, and see how NAFLD can be associated whether with vascular disease or polycystic ovarian, gallstones, every organ, you name it, it's there, and even malignancy. So many problems can be associated with NAFLD, and that's the reason why we have this masterclass today. When you talk of NASH, even worse, 1 out of 20 people who are in the audience may have NASH. That's the prevalence we talk about in the general population. But the sad part is, large part is undiagnosed. Global prevalences, Dr. Rucha will take us through the details, but it varies. Little high in the Middle East, about 30%. But the problem in the Asian continent is, we all know, we have more fat, we have more ectopic fat. In a study that we did here in Vellore in the obesity clinic, about 3/4 of our patients had NAFLD. So that's the reason we have this masterclass, and we have the country's best orators to talk about it. We would have Dr. Rucha addressing the importance of NAFLD from a clinical point of view, the associations, who should we screen. Dr. Alkamash will take up how we are going to screen and what we really need to ask for investigations, and Dr. Meenal would talk to us about management. So with this, I'll stop here. I request the audience to please put in their questions in the chat box, and I would request Dr. Rucha to take over. Dr. Rucha, should I share the slides?
Yes,
or
please.
You're able to do? Right. So I would share Dr. Rucha's slides, and over to Dr. Rucha for talking about the prevalence.
Great. Thank you for that wonderful introduction and setting the segue. And let me just tell you, we are honored to have Dr. Nitin as our EBM lead. And in the last 10 days, he has kept us all on track, sending us articles, making sure, we are all on board and kind of in a link. So since I have 7 minutes, I will get started. To me, I feel we've been talking about the word pandemic. So I sort of have slides, but I like to also just kind of make sure we are all sitting back on a Sunday morning and learning something. That certainly there is this COVID pandemic going on. And today we are talking about obesity and diabetes. And when 10 years ago, it was when a patient of mine told me that how come no one really monitors my fatty liver at each visit? And this was in the US. And it struck me. And now, of course, we all accept and clearly screen our patients that we shall be talking about for NAFLD or non-alcoholic fatty liver disease. So the post hoc analysis from the Imagine-1 and Imagine-3 trial shows you over here that the type 1 diabetic patients have a much lesser incidence, as you can see, or a prevalence, 9%. But once we start talking about our type 2 diabetics, this number goes up. So it clearly will give you an idea. And Dr. Kapoor also showed us the data from our Indian patients down in CMC Vellore. So 76% of insulin naive patients and almost 60% of patients who are on insulin in this particular study had hepatic fat fraction more than 6% by MRI. So certainly, I would say if 70% of your patients with diabetes have NAFLD, you need to be screening all of them. Next slide, please. So how will you predict? The next thing is, if I have NAFLD, why do we need to worry about it? As an individual, as a community, as a diabetes teaching community, and today's Teachers' Day, so we hope to walk away with something we learn, that NASH has adverse outcomes for your patient, but also at the global level, at the country level, at the national level. By 2030, this prevalence of NASH is going to increase much more exponentially, almost 63%. Advanced fibrosis is going to increase. And once we start getting into cirrhosis, this is going to affect our mortality, and the liver deaths will again multiply, as you can see over here. In the US, almost 30% of the adult population has NAFLD. And this is something that we can arrest, we can reverse the progression. So I will just show you in our next slide as to how can we work on this, what is the level where we can work at. So I thought this was a nice study to put because it has a lot of different populations. So you have from the US study based on ultrasounds, you have enzyme-linked NAFLD, you have biopsy-linked NAFLD. You also have Dr. Amrapurkar's study from 2007, which is Indian data. And you can see the prevalence of NAFLD varies depending on which population you are looking at. But across the board, it seems to be really all over, all across. I personally feel this number has increased because of these annual checkups and people getting more and more screenings. So awareness on the part of the doctors and awareness on our part. So next slide. So why should we worry about it? Controversies of normal levels. Altamash will address all of that. Next slide, please. So in the last few seconds, I'll just sort of talk to you about the prognosis and pathogenesis. The reason we also worry about it, that if it's untreated, and Dr. Nitin showed you already, it will progress further to fibrosis, cirrhosis, conversion probably to hepatocellular cancer. And again, this risk of cumulative rate of conversion is much higher in our patients with diabetes versus non-diabetic. Also, if we arrest it early on, we might think about liver transplantation, of course, based on the underlying etiology. Next slide. Mortality also, as you can see, gets higher as you go from no NAFLD to steatosis to NASH. So morbidity, mortality will drive our treatment and guide us as to what we should do. Next slide. So this is the spectrum already discussed. Next slide. This is the pathophysiology, and I think Dr. Meenal will come back to this when she talks about. So in this slide, and this is my last slide, I just want to say is you want to think of the fatty liver now in a new terminology as the insulin resistant liver. No longer do we just talk about it as fatty liver, because that does not in our mind behoove us to guide treatment. You want us to think about this as the insulin resistant pathway, thereby increase free fatty acids, increase insulin, reduce adiponectin. This leads to initial lipogenesis and fat deposition. When the capacity of the mitochondria in stage 3, where you see decompensated steatosis, is overwhelmed, there are maladaptations to this increased free fatty acids. And really speaking, this is when fat gets deposited and you have more and more deposition leading to your destruction of the cells, fibrosis begins. Once there is macrophage activation and there is liver fibrosis, we may still have treatment options, but if we fail to arrest this, that's when we get into final stage and cirrhosis. I think I'll stop right here, Dr. Nitin. And
thank you, Dr. Rucha, for that very crisp presentation, very clear messages, talking right from prevalence in diabetes, more in type 2 diabetes, talking about progression, talking about mortality, and talking about the pathogenesis. And if I may just ask you to re-emphasize maybe one most important point for all our clinical physicians who've joined us, that when they are seeing patients in their OPD, when should they think of NAFLD? Just one important.
So that's fantastic. So yeah, I think, I did not want to. So whenever you have, so I would just list it as 5 points. There are more, but 5 things. Number one is if you in your clinic are diagnosing obesity, either by a BMI or more importantly by a waist circumference, and we have the cutoffs looking at 80 centimeters for men and 90 centimeters for women for the Indian data. We have that from Dr. P. Mohan's study as well as your study. Waist circumference certainly helps. Of course, if you have raised SGOT-PT more than at least 1.5 times, I would not even wait for 2 times upper limit of normal. You need to think in your mind, and you have ruled out all other related reasons for having a fatty liver. Number 3, if there is a strong family history of fatty liver cirrhosis, like my family, I've had my 30, 40-year-old cousins all have fatty liver linked cirrhosis, and we've even had HCC and death. So those are very key points to think of. Number 4, clearly diabetes, type 2 diabetes, of course, and severe dyslipidemias. And the 5th point I just wanted to put is there are several medications which can induce this nowadays. So I know that's sort of like off the beaten path, but you want to think of these medications, other lifestyles, alcohol. So all of these also will make things worse. I think I just want to put 5 risk factors, not talking about genetics. I have a slide on that which can be shared with the audience. So stop.
Thank you so much for that very crisp answer. Yes, obesity, diabetes, elevated liver enzymes, family history, and medications. That's what Dr. Rucha is telling us. This is what, if we see in our clinic, we have to ask for fatty liver. And maybe I'll take the opportunity of asking Dr. Meenal and Dr. Altamash if they have anything further to add in this segment of our masterclass. Dr. Altamash or Dr. Meenal? A short comment from each. Dr. Meenal, you are on mute.
Dr. Nitin, I think Dr. Rucha has already very briefly covered the entire spectrum of the diseased patients or the patients likely to be diseased with NAFLD and that really need to be screened. Just to add to that, yes, any person, even without diabetes and only coming to you for weight loss or obesity, as the first point she rightly said, maybe in that spectrum, we can also include the young girls with PCOD or the hypothyroid patients for that matter, or even the hypopituitarism for that matter can be included when we need to screen for NAFLD.
Absolutely. Totally agree. Dr. Altamash?
I think I concur all the slides and whatever has been spoken till now. I think a very important message from this part, I would take it as this: NAFLD is one of the most widely prevalent liver disease worldwide, and we are yet to come to a final conclusion of a proper diagnostic test as well as a confirmed treatment. So I think with that, over to you.
Right, thank you. And maybe for all the physicians who are watching us, I think another important area that we sometimes see in NAFLD, which is sometimes ignored, is people living with HIV. And now with heart therapy, these people do live a very long life. these medicines do contribute to NAFLD. The disease process contributes to NAFLD, and that's another area to look at. And I think with this, we move on to Dr. Altamash to teach us more about how we screen and how we diagnose. Over to you, Dr. Altamash.
Slides visible?
Perfect.
Okay, thank you so much. I think the first thing that I'm going to tell is, why is it that everybody's saying we should evaluate? So reason why we should evaluate is we should identify first the patients, those who are at risk. And one slide was shown by the previous speaker, to risk stratify in which patients you would want to be really worried, you would be really speculative, and you would be really moving ahead of some treatment that we have to offer, and to focus care on those patients with NASH, which is available. So I think very elegantly, both the previous speakers and of course our EBM lead showed that diabetes and obesity are one of the important factors that need to be considered. And this was one paper which talked about that not just type 2 diabetes or obesity, but also you should look out for people, those who've got pre-diabetes. I'm going to take this very quickly, how you are going to get into this. But importantly, if you look at these two values, you should not wait for SGOT-PT to rise, because in 80% of the people, SGPT can even be normal with advanced cases. This is another clinical pearl that I wanted to give it to our audience, since it's an EBM and risk factors just covered. It's also important, do not just investigate in the line of NASH. You should have a broad understanding about which diseases you should look forward, you should rule out, and then go for NAFLD, because finally it's a diagnosis of exclusion. Another clinical pearl that now it is called not NAFLD, but MAFLD, Metabolic Associated Fatty Liver Disease. So the way we have in PCOS that LH-FSH is not to be used for, the ratio is not to be used for diagnosis of PCOS. Similarly, please take the message that the OTPT ratio is not to be done to rule out NASH, because it can be completely dissuading us from the diagnostic path. Now, what is important is two things: the biomarkers, non-invasive part, the imaging part, and the invasive part. So various authorities across the world, whether it's the UK Association of Liver Disease, whether it's in Asia Pacific or the American Society of Liver Diseases, everybody says that two types of scores should be used. And I'm going to show you very quickly in one slide how to use these two scores, which was our main aim to get this particular talk. And this is what we are going to look into, how to use these two scores. For those who are first timers, NAFLD score as well as FIB score are completely readily available on the click of a button on your phone. These are two medical calculators as you use to calculate eGFRs. What you need is to enter the age, SGOT-PT, platelet count in some. I'm sure questions would come on platelet, BMI of the patient, albumin, and impaired fasting glucose or diabetes, whether it's present or not. So automatically the diabetes, that article that I showed about pre-diabetes is here, and it is one of the factors. Importantly, once we have a value and it has got a very good amount of negative predictive value. So these scores, once they are low, we are quite sure that NAFLD is not there over there. And if the values, these, do not be worried about these numbers, because these are the calculators which will do. We just need to feed these values. For NAFLD, anything that is more than 0.6 would predict the fibrosis, and it has got a good NPV or PPV. And for FIB score, if it is more than 3.25, after entering the values, the cutoff would be then with a high probability of F3, F4, or the fibrosis stage 3 or 4. Once they are indeterminate, then we have certain other tests, which I'll show you as we move ahead. So these are the two scores which are really clinically practice-changing scores, and it's important. They are very simple and should be used. I think what Dr. Rucha was talking about, her patient talking that nobody is looking into my parameters. This is one score that we can relate to the way we relate with eGFRs with the chronic kidney patient. Apart from these markers, we have sonography that can be done, but again, only if 30% or more steatosis is there, then only sonography helps. Otherwise, sonography will also give you a normal value. So a mild fatty liver may be missed if we are relying only on SGPT and sonography. So that's the catch over there. And we have enhanced scales like AFRI or the vibration controlled transient elastography or the TE or the transient elastography. There are many scores, there are many type of other investigations that can be done, but these are the 5 slides that I want to give for this EBM. And that this is one factor which is quick, bedside, it takes 5 minutes, it's accurate in detecting, but is limited by obesity food intake. And of course, it is a operator dependent thing. I think the last thing that we would want to do is the liver biopsy, since as physicians, we do not perform liver biopsy as endocrinologists and as physicians. I think we would wait really till this particular stage and keep this always at the last, because there are a lot of tests that could be taken. So importantly, if you look at the screen now, if the patient is positive with the earlier slide that I showed you, slide number 2, and any of those screen positive things are present, it is not NAFLD, then it could be either your hemochromatosis or a Wilson's disease or autoimmune hepatitis or something else. If your liver screen and sonography are both negative, then it is something else, some other disease. But if your screening is negative, but there is more than 30% fat and you see a mildly disease present on sonography, then you have to do the non-invasive assessment of the NFLD or the FIB score. And if required, as I said, you have to use those calculators. If it is low risk, then Dr. Minal will take over from here. But in low risk, there are certain markers that come up, whether it is CK18 measurement, which is currently not available here with us, or whether it is P3 N-prot collagen peptide, which is also again not available. And there are many other biomarkers of metallic proteinases and metalloproteinases, which if is low, again, it goes to lifestyle. If it is high, you go for a high risk, or if the patient has got scores, these are the 2 scores that I showed you. If you fall into intermediate risk, then only liver biopsy. However, it's the patient also who should be considered into this treatment discussion and decision tree. If the patient refuses for the biopsy, then we know what the treatment or how we would proceed in that direction. As I said, if they both are negative, seek diagnosis through something else like presence of metabolic syndrome, check use of MRI, MR spectroscopy, diagnostic or other monitoring devices or designated gastroconsults. So I think I would really like to conclude by saying that the summary of markers, why do we investigate NASH and what do we do? What do we learn? So the 5 lines that those are important in the current scenario that we see for NAFLD NASH in evidence-based modalities, that the SGPT levels are poor predictor of NAFLD. Ultrasonography is the first imaging test that can be done when you suspect steatosis. But however, the accuracy of sonography is good only if more than 30% of liver cells are steatotic. Otherwise, as we saw in the slide, this also can come as normal. Liver fat decreases as the fibrosis increases. Dr. Nitin and Dr. Rucha both showed how the liver transformed from a fatty living to a fibrous looking to a cirrhotic looking to a cancer. So that's where we need to understand that SGPT, that's the reason, may not rise. The risk of NAFLD and NASH are directly related to the presence of and severity of metabolic syndrome. And let me tell you, as I earlier said, that NAFLD is one of the most common liver disease worldwide. Similarly, metabolic syndrome is also one of the very commonest entity that can lead to the risk of NAFLD and NASH. Simple steatosis carries benign prognosis, and that is why I showed you in slide number 1 that you need to risk stratify and then only move ahead. The risk stratification 3 prongs are low risk, intermediate risk, and high risk. Why do we risk stratify? Because the prevention or the treatment part, which my next speaker will talk, are going to depend on those 3, and that NASH carries poor prognosis as shown by the earlier speaker, whether related to liver, related to kidney, or most importantly, related to cardiovascular mortality. I think with this, I would give it over to Dr. Nitin Kapoor.
Thank you. Thank you, Dr. Altamash, for that very crisp and also very much well within time. And maybe just taking up from there, and thank you, really, you told us, who to screen, you told us what are the secondary causes that we need to look for, and you told us, more importantly, what are the key risk factors and how we have to really screen them in clinical practice. There's one thing that you mentioned, the very important FIB4 and NAFLD score, and a very good analogy you gave, like GFR. We don't measure GFR, we just approximately estimate it, and similarly are these scores. But one thing that stands out in these scores is, yes, we talk about liver enzymes, the importance of glucose, the importance of age, but how does platelet count fit in with liver disease? And if you could throw some insight on that.
Of course. So platelet count definitely comes down when it is cirrhosis. So we know that it is actually a inversely proportional or a bad prognostic marker. And that is how a lot of these people come also with bleeding tendencies. So it's a very well known fact, even with biopsy proven cirrhosis, and whether it's alcoholic or non-alcoholic, that platelet counts do reduce. So it is one of the important prognostic marker. And thrombopoietin also may have some role in with the liver and hepatocytes over there. And I think that's the reason why we will not be able to evaluate with if platelets are of big size, or there are megakaryocytes, or if the patient in the recent past has had a dengue fever or a malaria, where then it comes clinically obvious that we need to wait till the patient is stabilized and then only use platelet count as one of the markers. So again, it's a very important to understand that, as I said, rule out other causes of liver diseases. So if the patient has had any kind of hepatitis or a cause of fever causing high SGOTPT, then we do not evaluate in that line at all. So any cause of low platelet also has to be taken into consideration for this.
Thank you for that insight. And for all our clinicians today, yes, we ask for liver enzymes, and platelet count is also something that we can click on when we ask for investigations for fatty liver. Maybe I'll take a question, more clinical question. Maybe I'll request Dr. Rucha to answer this. In clinical practice, sometimes when we refer, we suspect NAFLD, as both of you clearly told us how to do it. We send the patient for a sonography, but many times these patients have severe obesity, and the report comes back, there's suboptimal optimization. Do you see this in your practice, and what do you do when you get such a report?
Yes, all the time, and I mean, you clearly know there's fatty liver and the report comes normal, and you're wondering if the radiologist was taking a break. You sort of, I don't want to bash up anybody, but yeah, at this time, so it really is a gut feeling. You need to understand and you need to explain to your patients. The reason I mentioned that 1.5 times the upper limit of normal for ALT, AST, even though, as Altamash was saying, don't put all your weight on it. There's a very nice paper by Dr. Kuzi, just recently, wherein they correlated the AST, ALT to the intrahepatic triglyceride content. And at 1.5, and we said more than 5% steatosis is when you start thinking about NAFLD. So they correlated just at that level of 30-40 SGOTPT, that your steatosis is about 5 to 6%. And that's the reason why. So that is one guide. Number two comment is just to bear in mind, all these scores have not been validated in the Indian population. So that is another thing, is these are, in fact, they are very nicely done by an Italian group, and most of it is in European and Caucasian data. So we don't have Indian, and I'm hoping Dr. Nitin's group or all of us get together and we can come out with what is a score for us. So really waist circumference, understanding the metabolic parameter, if there is evidence of metabolic syndrome. I really think I do like to get elastography. So when the sonography is, if you have access to fibroscan and sonography, the validation and the positive predictive value is quite high for those two tests, almost to the extent of 90%. And I would hope the FIB4 score also, it has a positive predictive value of almost 80 to 90%. So we could use it for Indian population. So that's too long an answer already. So I'll stop.
No. Thank you. And
Can
I
I just
think we're
add?
doing... Yes, please.
Okay. So I agree that these scores are not at all validated in our population, but there is also one more score, that's the Brazilian score, which takes into consideration about BMI and other factors. And there is one Chinese study which talks about neck circumference in NAFLD and neck circumference height ratio with NAFLD in women in men and women both. So both these have been a centimeter more or 1.5 centimeter, and they've been significantly correlated. So taking forward with Dr. Rucha and Dr. Meenal, I think, Dr. Nitin, we would request you and Dr. Neeta to take this as one of the scientific research question. Why not we validate the neck circumference? Why not we validate these scores for our own population. Dr. Meena Chabra, Dr. Shalini Jaggi, Dr. Anjali Bhatt, a lot of people are over here, a lot of senior people. I think this should be one of the evidence-based forming session also. And maybe next time we present this data. And I can see both the ladies over here smiling, and Anjali also is just there. So I think let's keep this in mind, a research question. Thank you, Dr.
I have
Rucha.
a question. Can I ask you, Ultimate?
Yes,
Yes,
Dr.
my
Meena.
question is, our patients could be on antiplatelet medications because they are diabetic. So does that affect the platelet? So is that some of them might be on antiplatelet medications? And you're talking about, so is it a validated?
Very valid question. I think before the validation. So I think, so when we give antiplatelets, we are not looking at the numbers do not reduce. It is the aggregability of the platelet that reduces. And what we are using for the NFLD and the FIB score is the platelet count. And the count decreases in those diseases processes where there is an inflammatory reaction over the bone marrow and over the blood platelets where the toxins kill the platelets. So it's the number of platelets, and also in some normal people where there could be an association of increase in size of platelets, that's the megakaryocytes. So the interpretation of the report got to be very, very importantly helpful. Thank you for that question, madam.
Right. Thank you, everyone.
I think it is also the enzyme and platelet index that is also calculated.
Platelet index.
Yes. So there are many of the scores. So BART score is also there, and there are 3 genetic scores which have come. I think we had a discussion with Dr. Nitin that
regarding the platelets I'm talking. Keeping limited to platelets, maybe it's the platelet index also that we take into consideration.
Yes, we do take into consideration.
Yes, and maybe, I think conscious of time. Thank you everyone for those inputs. And
so
maybe
Nitin, one word about thin NASH. What do we tell them? We've seen people with raised liver enzymes and liver fat, and they're thin. So a little word about thin NASH. Do they have a better prognosis than the fat NASH, or are they potential diabetics? So should we screen them very aggressively for type 2 diabetes in the future?
Absolutely. So very good question. And I would say that was the work of my PhD on looking at normal weight obesity and looking at people who have absolutely normal weight but high body fat, especially the ectopic fat. And what we did find there is the prevalence of diabetes, hypertension, and dyslipidemia was almost at par with those who fall in the obesity category. So like we say for thin PCOS, they're no better than those who have actual PCOS. Very similar. Those who have thin but high body ectopic fat are equally at risk, and we need to take that seriously. It becomes more challenging to convince the patient to, kind of follow lifestyle when they're already thin, but I think that's a fact, and that's a phenotype that we see in our Indian setting. And I think we are really looking forward to listen to Dr. Meenal to what exactly we tell our patients with respect to treatment, whether it's lifestyle, drugs, and when do we go to those adverse or I might say the bigger steps like surgery. And Dr. Meenal will talk to us about the management of NAFLD and NASH. Over to you, Dr. Meenal.
Thank you, Dr. Nitin. Thank you so much. And Dr. Neeta ma'am, thank you so much for this platform here. Not wasting much time, 7 minutes I have to justify the treatment. So NASH, how do we manage? After listening to Dr. Rucha and Dr. Altamash, I will just begin with the very first slide, which says that this part has been covered by Altamash, saying diagnosis, evaluation. Now, moving to the management, as Dr. Meena has already set the stage for me, that it may be the entire spectrum beginning from just a fatty liver to an steatohepatitis or to the end-stage cirrhotic or a fibrotic liver. Step 1 always remains a lifestyle intervention. So lifestyle intervention is across the spectrum, right from the fatty liver to the cirrhotic liver. Once we have established a steatohepatitis or the cirrhotic liver or a fibrotic liver, it is then we think about the pharmacological therapy, which is directed towards the steatohepatitis liver. I've been asked specifically about the bariatric surgery also. And yes, bariatric surgery is coming up with a very clear idea that the disease NAFLD is targeting, as we all know, it is targeting the fat or the obesity. So bariatric surgery plays a very important role. And finally, it is the liver transplantation, which is the answer to the last stage of fatty liver or the NASH. So beginning with the lifestyle guidelines in NASH, we have the diet programs and we have the exercise programs, which are targeting the weight loss to begin with. And we all know calorie reduction leading to weight reduction. Exercise, of course, again, tailored exercising, that is both aerobic and the endurance exercises, and the bariatric surgery. Ultimately, the idea is to reduce weight, BMI, and the fat. So we have the answer here that if a 10% of the weight loss can be achieved and it can be maintained for almost 1 year, we can even target a fibrotic regression. So that is a very positive hope here. Coming to the pharmacotherapy of NASH, all the international bodies, beginning from American Association to the European Association to the Asia Pacific Association, we all know that the idea is that it is only when we have a biopsy proven NASH, or we have a fibrotic NASH, fibrosis already setting in, or we have a group which is most likely to progress to fibrosis, there we introduce pharmacotherapy that is going beyond lifestyle intervention. When we talk of pharmacotherapy, we always have to remember, so far, everything is off-label. We have no FDA approval so far to treat NASH. We are treating off-label. And diabetes or without diabetes, the two commonly used molecules are vitamin E and pioglitazone. Vitamin E and pioglitazone has, and this is EBM, that is evidence-based model or management we are talking about. So we have to discuss one word, that the famous trial, the PREVENT trial, which is giving the data of pioglitazone and vitamin E in NASH at 2 years interval, and both have shown significant benefit in terms of NASH and cirrhosis. Then we have a number of studies with vitamin E, and the meta-analysis shows that vitamin E does play a positive role in reversal of fibrosis and progression of NASH. Similarly, we find that the transplant-free survival or the hepatic decompensation is decreased with the usage of vitamin E. Pioglitazone has been used in a number of studies, and a meta-analysis of these 8 studies show that pioglitazone can be used even in population without diabetes, but with NASH. Another 18-month study in pre-diabetes, as Altamash was right in saying that pre-diabetes also counts in when we are talking about NASH. So pioglitazone has a role in NASH, but we have to consider the side effects of both the molecules, which are all well known, and it has to be a weighed approach. Then coming to the role of statins, again statins, because we all know NASH is another marker for cardiovascular mortality and morbidity. So we need to have drugs that also decrease the CV mortality and morbidity. So statins also play a role, and statins have also shown to decrease portal hypertension and cirrhosis. Coming to the most important part, that obesity is the underlying factor for NASH or NAFLD. So are we targeting weight loss? And incidentally, we do have very good molecules in our diabetes management basket targeting weight. So we have GLP-1 RAs with us and SGLT2I also. Though we do not have any specific data as to their role in NASH so far, the studies are underway. But we have the lean trial with liraglutide. We have semaglutide now coming up soon. And the SGLT2I also having a very significant role in weight loss. So far, our current approach to treat NASH is control obesity by lifestyle, by anti-hyperglycemics like GLP-1 RA and SGLT2I, or the bariatric surgery. Reduce the CV risk with statins, controlling blood glucose, blood pressure, and the lipids, and smoking cessation, of course. Targeting NASH with vitamin E and pioglitazone, and end-stage complications can be targeted with statins and metformin. This is so far the management we do have in our hands. Going a word beyond, what is the future for NASH? We have a lot of molecules in phase 2 trial, like the galectin-3 inhibitors. We have the FGF2 analog or the FGF19 analogs. We also have the twin cretin now coming up, that is tirzepatide. So these are the molecules which are still in phase 2. We also have few molecules on board with us, though again not proven, not used very frequently, but we do have molecules like CCR2 and CCR5 antagonist, that is senicriveroc. We have elafibranor, that is the PPAR alpha and delta alpha and sigma agonist. Then we have the farsinoid X receptor agonist, that is obeticholic acid, which is in market. We have the thyroid hormone receptor beta agonist like resmetirom, and we also have the SCD1 inhibitor aramcol. But these are all in phase 3 and phase 4 studies so far. They still need clinical endpoints for full approval, and we need some histological endpoints for the partial approval. So the last slide, we are still not clear about how do we treat our NASH patients and prevent them from progressing. We have the metabolic armamentarium with us already. We need anti-inflammatory, we need anti-fibrotic, and also we need some anti-apoptotic molecules. So that is all about the treatment and future of NASH. Thank you. I hand over back to Nitin.
Thank you so much.
The
Dr.
last
Mehta.
slide that the present algorithm, we can still just remain focused, treat this hepatic steatosis, that is the fatty liver level, with lifestyle and severe risk. If there is established NASH and fibrosis, introduce pioglitazone and vitamin E. In diabetic population, you can also consider SGLT2I and GLP-1 RAs, and with cirrhosis, liver transplantation is the answer.
Thank you so much, Dr. Meenal. I think that was a very difficult job to condense the entire treatment in 7 minutes, and you've wonderfully done it. You've told all the important aspects, right from diet. More importantly, I really liked it the way you stress it. It's just not the weight loss, but the weight maintenance that is important. You talked about the drugs. You talked about the newer drugs, and believe me, the early data from semaglutide, tirzepatide, as you mentioned, is really promising. And then you spoke about the surgery as well. Dr. Meenal, I have a question for you, and this is going back to the clinic. And as you said, the lifestyle intervention is the first thing that we need to ask our patients. So what do you tell your patients? How much weight should they lose when they come back to see any good, evident improvement in their NAFLD?
Dr. Nitin, that is a very subjective question, but yes, the standard approach is we always ask them to come back at least losing 2 kgs a month. That is a half kg target per week we give them. And we emphasize that, okay, even if suppose they fail, it's not disheartening, but at least do not gain weight. So that is the most important thing that I tell my patients, that, okay, even if you have not been successful this month, you have not gained. So that is also a very positive approach. And then, of course, we need to revise our prescriptions also, because maybe some of our molecules like sulfonylureas or other molecules may be rather helping them to put on weight rather than losing weight. So maybe we can revise the prescription also, shifting towards SGLT2Is and GLP-1 RAs if we are talking of the diabetic population and obese population. Non-diabetic population, yes, of course, it's diet, exercise, low carbs, and a target of half kg per week.
Absolutely. So 2 very important messages coming up there. Yes, the slow and steady weight loss approach is good. People may do enthusiastic diets, lose a lot of weight, and then gain back after a while, which is not going to be helpful. So yes, slow and steady, and thank you for bringing that. And the second important message that Dr. Meenal is telling us is about look at the comorbidity, the concomitant medications. Is there something in the prescription list that is adding on to their weight? And do we need to change that? And maybe, Dr. Meenal, for the clarity of our audience today, would you like to say if the patient has diabetes, which are your better drugs and which are not so better drugs for in a patient with NAFLD? You did allude to it in your talk.
Yeah, as we all know, the age-old molecule metformin is the first molecule which we always consider as at least it will help you, if not lose a lot of weight, but at least it will not help you in gaining weight. So it will at least help as a weight maintenance molecule. Then, of course, now we have the SGLT2I and the most important and the approved molecule, that is GLP-1 RA. So if we can talk of liraglutide, which has been actually approved as a anti-obesity molecule or weight loss molecule. SEMA is coming up soon, which we can, in fact, offer as an oral molecule also, that they might, because injectables is another runaway for patients. So the oral molecule, again, might help us in convincing our patients for weight loss and anti-obesity molecules. So these are the molecules, and at the same time, avoiding molecules like sulfonylureas, which make them gain weight, or insulins directly, especially the short-acting ones, they do help them in gaining weight. So these are the molecules which we do away with, and we add preferably the GLP-1 RAs and SGLT2Is.
Meenal, why do you forget glitazones? Because they are the only drugs that have shown
glitazones. Yes, very much
they
true,
may
ma'am.
increase weight,
Yeah.
but
I was
we
purposely,
use...
I was purposely
No.
not using. I was purposely not using the word glitazone, because when we are talking in a class of NAFLD, glitazone is the one molecule which is being used for NAFLD. So, and this is a very contradictory molecule. On one hand, it is helping us in NAFLD. On the other hand, it is making the patient gain weight. But still, it has a role in NAFLD. So this molecule is very contradictory if I talk in this class. So I was just avoiding using this molecule.
No, but I guess it's the cheapest molecule, and it causes redistribution of fat. So I think glitazones. What about E, vitamin E?
Nitin, a short question.
Yeah, doctor.
Patient of NASH treated with fibrate responded with a triglyceride lowering and continued chronic therapy without weight loss. We have suppressed FFA release. Can we take it as a prediction with a moderately controlled diet that patient is controlled for NAFLD if there is an improvement in enzymes with a fibrate treatment?
So
Dr. Mehnal,
if you allow me. So if the progressive follow, the subsequent follow-up of the patient is showing that there is no further increase or worsening of steatosis, like there's no worsening of inflammation, and there is no worsening, if you can control the inflammation without compromising fibrosis, then definitely your job is done. But if you are worsening fibrosis at the cost of controlling inflammation, then the patient is worsening, that the patient is progressing. So idea in NAFLD treatment is controlling inflammation as well as not allowing fibrosis further. If that job is done, then yes, we are doing our job rightly. So weight loss is one way of controlling, it's an indirect way of controlling the fat, indirect way of controlling intrahepatic fat and fibrosis and steatitis.
When weight loss does not happen, how do we know lab marker that fibrosis is not progressive? We don't have
the Altamash will answer that, but we do have fibroscans. As a progressive fibroscans can be done probably to tell us that the MR scans can be done. There are spectroscopes also that can answer that. Yes,
Can I answer this question?
Yes, please, Dr. Rucha.
So there is an index we did not talk about, and which is actually kind of right now being trying to be validated for the Indian population, known as the fatty liver index. And this might answer your question, Dr. Sanjeev, is it takes into account two really nice parameters: waist circumference triglycerides, GGTP, and the liver enzyme. So this is something, as you clearly asked, if we can look at BMI, triglyceride, GGT, these are things we can clearly measure, and that might give us an idea if the fatty liver index is going down. Very simple in our scenario, clinical interpretation of the fatty liver index. Secondly, we did not talk about saroglitazar. So we may not like pioglitazone, but saroglitazar last year in March 2020 got approval for treatment in NASH, not just NAFLD, but NASH by the DCGI of India. So I think just a quick word about the PPAR alpha pathway and the PPAR gamma pathway are the strongest indicators. So I think saroglitazar deserves a mention because it did get approval.
Yeah, as Rucha is right, the PPAR pathway is very important, and that is why we are also having the dual, the elafibranor is coming up, is a PPAR alpha and PPAR sigma pathway blocker.
Right. Thank you, everyone. I think it's been a wonderful discussion. We've learned a lot, mentioning right from all the drugs, lifestyle, and surgery. Maybe just before we conclude, we've got 20 seconds, and maybe I'll ask Altamash to give a final word to end this masterclass. What do you want our audience to take away, Altamash?
Look into NASH, calculate the scores that have been told, and slow weight loss, steady weight loss, and stay with that weight loss. Time's up.
Thank you so much, and thank you all the experts. I think they've done a wonderful job to concisely deliver these very important topics. Back to Dr. Anjali.
Right. So this is what we meant when we introduced this concept of EBM masterclass, where we take up 4 thumbs ups that Dr. Altamash told us, and then an n number of questions and researches and all other things that we talk to each other and come up with better manage our patients as we discussed. So thank you so much to Dr. Nitin, Dr. Mehnal, Dr. Rucha, Dr. Altamash to make this discussion such a wonderful and